notes, you can just stop me there and add your notes. So today I'll talk about the great vessels trauma, a injury to the aorta and great vessels of the thorax may occur secondary to penetrating or plunge trauma. The management strategy involves control of immediate hemorrhage with prevention of the distal malperfusion or pseudoaneurysm development and rupture. So the most common site of aortic transection is the isthmus, and after that, aortic transection at the base of the innominate artery is the most second site of injury. The base of the left subclavian artery and the base of the left carotid. So central venous structures are rarely injured with the plantar trauma, but this can occur with the penetrating trauma. Traditionally, open surgical repair of these injuries has proved effective, with the growing shift from open repair to TIVA as the primary treatment in patients with plantar trauma. Outcomes have improved with significantly reduced mortality and morbidity, including procedure-related paraplegia. So first of all, I'll talk about the zonal division of the thoracic aorta in order to facilitate international correspondence and clinically more useful system with regard to anatomical identification of the thoracic aorta. An anatomical endograft landing zone map was advocated at the first International Summit of Thoracic Aortic Endograft in Tokyo in 2001. So we'll use this landing zone map to classify not only the proximal deployment site of the endograft, but also extent of the open surgical repair. So as we see that the ascending aorta is considered as zone 0, then the left common carotid as zone 1, left subclavian zone 2, aortic isthmus is zone 3, and the descending is zone 4. Aortic carotid repair as the double 0 site. So clinical presentation, patients who presenting to the emergency department with injury to a great vessel should be evaluated according to the ATLS protocol. Plantar trauma victims are often hemodynamically stable. Suspicion for thoracic vascular disruption must be based on the mechanism of trauma. In addition to high-speed collisions involving vehicles or motorcycles, crush injuries and fall from height often have sufficient force to rupture thoracic vessels. There are often clues evident in the initial evaluation of a trauma patient that can suggest aortic disruption. So in contrast to blunt injury to the arch vessels, patients sustained distinct thoracic aortic rupture are often hemodynamically stable on presentation. So, patient may complain of dyspnea, back pain, and display differential blood pressure in the upper versus lower extremities. Specific signs or symptoms of aortic rupture have been identified less than 50% of the cases. Complete degulving injury may result in intussusception of the aortic media into the descending thoracic aorta, with the resultant of pseudocoarctation and degree of distal malperfusion, as it's shown here. It shows the pseudocoarctation of the aorta caused by circumferential transection of the aorta with a wall flap. So commonly associated complaints including neck and chest pain. During physical examination may reveal ecchymosis across the chest and neck from the seatbelt shoulder harness, supraclavicular swelling or pyrrhea, diminished pulse in the ipsilateral upper extremities, neck hematoma with or without tracheal deviation, acute Horner syndrome, acute suburvena cava-like syndrome. And stab or gunshot wound located between the mid-clavicular line or zone 1 of the neck. And I mean by zone 1, that the air between the thoracic inlet till the cricothyroid membrane. Great vessels penetration should be suspected. Pyrrhea suggesting AVF formation may noted up to 30% of the patients. Penetrating distal subclavian injuries may demonstrate pulsatile bleeding during initial evaluation. More commonly, patients suffering penetrating injury to the chest or neck will be hemodynamically unstable on arrival, possibly with evidence of cardiac tamponade. So hypotensive patient may proceed directly to the operating room without diagnostic imaging, since the mortality is nearly 3 times greater than the stable patient. An organized, efficient, and effective evaluation of these patients is necessary to prevent unnecessary loss of life. So classification system for traumatic injury. We're having 4 grades. Grade 1 demonstrate an intimal tear or flap. Grade 2 demonstrate an intramural hematoma with significant change in the external contour of the aorta. Whereas grade 3, a pseudoaneurysm with extension beyond the normal contour of the aorta, and grade 4, where it is the rupture of the pseudoaneurysm. So initial evaluation, just something to mention that the Society of Vascular Surgery guidelines recommended that TEVAR for the grade 2, 3, and 4, where the grade 1 injuries typically heal spontaneously. So initial evaluation, the primary and secondary survey routine, radiograph, hemodynamic stabilization of the patient, and regular investigations. The first step in diagnosis a blunt traumatic aortic injury is identifying the at-risk patient. Motor vehicle collisions, fall from height, explosions, and crash injuries have the impact and deceleration forces required to cause aortic transection. These patients should go imaging directed at ruling out this potential fatal injury. So the operative management of the intracranial space occupying lesions and intra-abdominal hemorrhage take priority over non-bleeding aortic injuries. Hemodynamically unstable patient with sign of exacerbation hemorrhage should go directly to the operating room for controlled hemorrhage and TEE used to evaluate the aortic injury. Emergency medical resuscitation in the field have provided more patients the opportunity to reach the hospital and receive aggressive definitive care. So inshallah, we will reach this level. So a clue that's suggesting aortic disruption as the history with the motor vehicle accidents, ejection from vehicle, motor airplane crashes, fall from greater crush or cave-in injury, loss of consciousness. And the physical signs when the patient came with a hemodynamic shock, fracture of the sternum, first rib, clavicle, scapula, cardiac murmur, dyspnea, back pain, hemothorax. These are the most common clue for that suggesting aortic disruption. So we'll start with the first imaging method, the chest X-ray. Part of the initial evaluation and to be examined for one of the 15 signs that have been associated with aortic rupture. So what is the 15? Most commonly of these 15 signs, which is in the chest X-ray, is the widened mediastinum to chest width ratio more than 25%, pleured aortic contour or irregularity aortic nope, when there is a first strip or multiple rib fractures, clavicular fracture. These are the most common signs which would on the X-ray. But 40% of patients with aortic rupture have had normal X-ray, which will take us to the second imaging method, which is the CT. In the typical hemodynamically stable blunt trauma patient, head and abdominal pelvic CT should be conducted to identify closed head or intra-abdominal injury. CT has become the screening tool of choice at most medical institutions to detect traumatic aortic injury due to its availability, speed, and ease of interpretation. Filling defect, contrast, exacerbation, intimal flaps, pre-aortic hematoma, pseudoaneurysms, and mural thrombi may suggest the presence of an aortic injury. Here we can see that a CT of a 30-year-old male after a high-speed motor vehicle collision, demonstrating an internal flap in the proximal descending aorta. TEE. So in unstable blunt trauma patient requiring ileoperitoneum, TEE can evaluate the descending aorta for evidence of rupture, or such as a mural flap or a thickened vessel wall, concerning for neural thrombus. Doppler mapping of the turbulent blood flow near a vessel wall abnormality may suggestive of blunt aortic disruption. Chronic atheromatous disease of the aorta can complicate obtaining the interpreting TEE images. It is an operator-dependent nature with sensitivity as low as 63%. Contraindication including cervical spine or pharynx, esophageal or maxillofacial fractures. The MRA vascular structures are well imaged by the MRA, particularly the thoracic aorta, and its utility in the diagnosis and follow-up of aortic dissection and aneurysms is firmly established. The time required to capture images inhibits the utility of the MRA in the acute evaluation of trauma patients. However, it may be effective as a post-therapeutic surveillance. The aortography useful when the CT or TEE fail to identify an injury. It may still be considered the gold standard. In experience, hand its sensitivity and specificity both approach 100%. With availability and speed of CT, aortograph rarely used these days. So we can see here an aortograph with the aortic transection at the isthmus of the aorta. So time-consuming, therefore, trauma patient with additional life or limb-threatening injuries should be otherwise stabilized before entering the endovascular suite. Rate of death of up to 10% have previously been reported during a diagnostic aortography, but this incidence has decreased significantly as endovascular proficiency has improved. Patients may suffer contrast reaction, contrast neuropathy, growing hematoma, or femoral artery pseudoaneurysms. So, decisions to repair versus expectant management. Hemodynamically unstable patients should bypass diagnostic imaging and be taken to the operating room directly. During controlling exploratory laparotomy or thoracotomy, TEE may be used to identify an aortic injuries. Aortic repair should not be attempted at this time. Patients benefit from the immediate transfer to the ICU for further resuscitations if the patient isn't stable. So once hemodynamic stability is achieved, anti-impulse therapy with beta blockers should be initiated to minimize aortic wall stress. The systolic blood pressure should be less than 120 and the MAB less than 80. Hemodynamically stable patient diagnosed with blunt aortic injury and lacking severe associated injury require intervention warrant immediate repair. Treatment of the non-life-threatening injuries should be delayed until after definitive aortic repair. Patients with thoracic intraperitoneal or retroperitoneal hemorrhage or intracranial bleeding that cause massive ficts should be managed with aggressive anti-impulse therapy to minimize the risk of aortic rupture. The aortic insult monitored by TEE during surgical repair of concomitant injuries and routinely imaged with CT during the delay management period. The mortality rate of the patient awaiting the aortic repair has ranged from 30 to 50%, but majority of this have not been related to the aortic injury itself. So we'll start with the ascending aorta. Mechanism of the injury: transmission of force through the thoracic cavity from the blunt injury caused torsion of the ascending aorta, leading to disruption of the wall with shearing effect on the heart. Additionally, a water hammer effect in an aortic occlusion at the level of diaphragm occurs with impact and high pressure wave, which go back and reflect back to the ascending aorta and aortic arch. Operative repair: pseudoaneurysms of the ascending aorta should be repaired using the bypass, femoral or axillofemoral cannulation bypass before sternotomy to decompress the stress on the aortic wall and pseudoaneurysm rupture on opening. After entering the pericardium, the pseudoaneurysm should be carefully mobilized if possible to gain proximal and distal control. Depending on the nature and extent of the injury, repair may be conducted by primary repair, patch, angioplasty, or prosthetic grafts. So if the aortic valve insufficiency is encountered, prosthetic valve replacement may be warranted. Deep hypothermic circulatory arrest is required, especially if the proximal and distal control cannot be comfortably obtained or the pseudoaneurysm extend into the proximal aortic arch. This will allow for excision of the pseudoaneurysms and closure of the aortic defect with prosthetic patch. Delay operative management may be considered in the hemodynamically stable patient with associated injuries at a high risk for bleeding. It must be discrete lesions without evidence of circumferential involvement or compromised adjacent structure regular assessed by a CT. So endovascular intervention in cases of ascending aorta injuries. Role of the TEVAR for the T-ring ascending aortic pathology is listed well now, especially in trauma patients, has not been evaluated and reported to date. Only a small number of studies have described outcomes with this approach of chronic aneurysm or acute aortic dissection and can be accomplished with promising early results. So we'll go to the next chapter of the lecture, the aortic arch branches vessels. Mechanism of injury to the innominate artery rupture as a result of anterior-posterior compression of the mediastinum between the sternum and the vertebra, displacing the heart posteriorly and to the left, thereby increasing the curvature of the aortic arch, increasing tension of all its outflow vessels. Hyperextension of the cervical spine with the head rotation provide additional tension on the right carotid artery, which transmitted to the innominate artery and can lead to rupture. The left carotid artery undergoes stretching injury with rapid declaration, producing an intimal tear and subsequent dissection. So in carotid artery injury, including hyperflexion of the neck to cause compression between the mandible and cervical spine, basilar skull fracture, transecting the artery itself and strangulating injury. Plant subclavian artery injuries are more common in the middle and distal third of the artery and are authorized to be caused by downward forces, fracturing the first rib with the anterior scalene acting as a fulcrum so that the subclavian artery is pinched between the first rib and the clavicle. Operative repair for the innominate artery. The second must coincide of the thoracic vascular injury. 83% were in the proximal vessels, 3% in the middle, and 9% in distal. The most common finding was disruption of the intimal with and media with pseudoaneurysm formation, as it's shown in this image, where it's showing a rupture of the proximal segment of the innominate artery and pseudoaneurysm formation. Surgical repairs has traditionally been performed by a prosthetic aortoinnominate bypass graft from the aortic arch to a healthy distal vessel through a full upper median sternotomy with extension of the incision along the anterior border of the right sternocleidomastoid as necessary. The entire length of the innominate artery should be mobilized to achieve distal control and the pericardium open to gain proximal control at the level of the aortic arch. After systemic administration of the heparin, a partial occlusion clamp is applied to the aortic arch and proximal anastomosis of the prosthetic graft performed into side anastomosis. Depending on the location of the extent of the injury, distal end-to-end anastomosis may involve only the innominate artery, or a Y graft may be required to reconstruct the proximal portion of the right carotid and the right subclavian artery individually. The origin of the innominate artery should be fully exposed and oversewn with the Blodgett non-absorbable sutures. In a healthy patient, typically tolerate temporary innominate artery occlusion caused by collateral flow. Patients with neurological abnormalities or suspicion, the cerebral protection should be used with a bypass and EEG, hypocirculatory arrest, or a carotid shunting. Long-term patency of prosthetic aortoinnominate artery bypass graft reported to be greater than 90 in 10 years. The carotid artery. Management must be directed at preventing cerebral ischemia and surgical intervention. Should be weighed against the observation and anticoagulation. Small intimal flap may resolve where a large flap can lead to a thrombosis and therefore requiring an anticoagulant uses. Arterial dissection may progress to a luminal narrowing, placing the patient in a high risk to thrombosis. So anticoagulation therapy is especially important in patients with bilateral carotid artery dissection, owing to the morbidity and mortality associated with bilateral thrombosis. As it's shown here in the image, it shows a pseudoaneurysm at the base of the right common carotid artery. When operative intervention is indicated because of the pseudoaneurysm formation, surgeon may bypass the lesion, but reconstruct it or ligate the lesion. Open repair of the intrathoracic carotid artery injury should occur through a median sternotomy with extension along the anterior border of the ipsilateral sternocleidomastoid muscle as necessary to gain more exposure. After gaining proximal and distal control, arterial repair may be accomplished by primary repair or interposition grafting with saphenous vein or prosthetic material. The subclavian artery carry mortality rate of 5 to 30%, resulting from the inability to obtain adequate hemorrhagic control through the direct pressure. Because of this close proximity of the trachea, esophagus, subclavian vein, and brachial plexus, subclavian artery injuries are associated with 40% morbidity. Operative exposure achieved by median sternotomy, limited sternotomy, supraclavicular incision, intraclavicular incision, thoracotomy, or combination of these depending on the location of the injury. Left-sided lesions are often managed through an anterolateral thoracotomy with either an intraclavicular or supraclavicular contour incision. So some surgeons perform median sternotomy for the proximal injury. Right-sided injury require median sternotomy with a supraclavicular extension. In injury of long segments of the subclavian artery, a portion of the clavicle may be restricted to optimize exposure, but this procedure consider a postoperative morbidity. When establishing proximal and distal control of the subclavian artery, the damaged arterial segment may be excised and the arterial reconstruction with the graft using saphenous or a graft. Ligation of the subclavian artery may be performed on critical ill patient unable to tolerate an extensive operation repair, and minimal short-term morbidity in the affected limb has been reported. When planning operative repair of the subclavian artery, concomitant injuries to the nearby structures such as subclavian vein and brachial plexus should be considered. So the endovascular repair, it's considering as the gold standard for the diagnosis and characterization of the intrathoracic vascular injury, and maybe become preferred method to treat a hemodynamically stable patient. The literature documenting the feasibility of the approach and minimal short-term morbidity and mortality, but very little long-term data exists. An analysis of the endovascular versus open procedure in the National Trauma Database revealed a survival advantage of the endovascular repair when controlled for the injury severity score associated with the injury and age. So, innominate artery, stable patients who have suffered either blunt or penetrating injury to the innominate artery have benefited from the endovascular repair with a stent graft without complication. One technical consideration when approaching the innominate artery for the pseudoaneurysm is whether the distal landing zone of the stent graft will occlude the carotid artery or not. Lesion that typically asymptomatic owing the extensive collateralization. And if the stent graft must transfer at the origin of the right common carotid, it can potentially be avoided by realignment of the guide wire such that the orifice of the subclavian artery will be covered. A subclavian carotid bypass may be performed before deployment. In carotid artery, embolic risk should be considered when assessing whether the lesion is suitable for the endovascular intervention or not. So many surgeons advocate for delay stenting of the carotid injuries. Safely anticoagulating the trauma patient with a concomitant intracranial or solid organ injury can be difficult. PTT between 40 to 50 shown to effectively cover the injury without increasing risk of bleeding. Full heparinization is viral during the stent graft deployment procedure and should be followed by antiplatelet therapy with Plavix for at least 2 weeks with subsequent conversion to a lifelong aspirin. Subclavian artery. Endovascular repair of the subclavian artery injuries has been relatively well described in the literature because of the obvious benefit of the procedure compared with the morbidity of the open subclavian exposure. So stent graft have effectively treated pseudoaneurysm, laceration, AVF, and complete transection of the subclavian artery, and theoretically reduced the incidence of brachial plexus injury. So interventional consideration unique to the subclavian artery has been the presence of approach vessels that may be covered by the stent graft and provide source of endoleak. If the contralateral vertebral artery patency and antegrade flow have been visualized, this branch vessels may often be coil embolized. If cannot be safely occluded, vertebral carotid transposition should be completed before deployment the stent graft. So stent graft repair of the subclavian artery may cover an internal thoracic artery that has been used as a pedicle in a cabbage case. So that will placing a risk for cardiac ischemia. Plavix for the 1 to 3 months followed by lifelong aspirin therapy. So compression of the stent graft between the clavicle and the first rib over the lifespan of a young trauma patient creates risk of stent fracture. So as it's shown here in the image where the graft is compressed between the clavicle and the first rib, both stenosis and the stent fracture, often asymptomatic, have been treated with balloon dilation and deployment of additional stent before going to open repair. The descending thoracic aorta typically occur in a motor vehicle driver, passengers, or pedestrian hit by vehicles. So alcohol or other substances abuse is involved in greater than 40% of these motor vehicle accidents. Patients ejected from a vehicle are twice likely to sustain traumatic aortic injury. So a seatbelt use can decrease the risk of ejecting from the car. Anyway, aortic transection is the most common vascular injury in a blunt thoracic trauma and to be identified 54% at the isthmus. The whiplash theory proposes that a combination of traction, torsion, shear, and pushing forces interact owing to differential declaration of tissue within the mediastinum, thereby causing adequate stress to rupture the aorta and at the isthmus. The ligamentum arteriosum, the left main stem bronchus, and the paired intercostal artery limit the aortic mobility. This is why the isthmus is the most common site for injury. The anterior thoracic osseous structures, such as meningeal, first rib, and clavicular head, rotate posteriorly and inferiorly and impact the vertebral column, pinching the aortic isthmus and proximal descending thoracic aorta, causing shearing of the aorta. So the pre-adventitial tissue around the isthmus appear to provide protection against free rupture and allow time for transfer to the hospital. So that will take us to the operative strategy. Mortality after an open repair has been approximated at 20%, and the morbidity rate may be as high as 14%, largely attributable to the incidence of spinal cord ischemia. So the TVAR of traumatic aortic disruption has grown immediately, and in current era, because the decrease of operating room time, complication rate, morbidity, and mortality. A prospective non-randomized multi-center trial of the endovascular aortic repair rescue trial on the 50 patients showed mortality within 1 year was 12%, and there were no conversion to open repair. Study demonstrate that TEVAR has favorable early midterm outcomes. Many anatomical details must be considered when choosing TEVAR for the traumatic aortic rupture in a young, otherwise healthy patient with normal caliber thoracic aorta. So, open repair, the major controversy regarding open operative repair of blunt traumatic involves spinal cord protection. Some still report safety and efficacy of clamp and sew technique, where the majority of surgeons have successfully reduced the historical 10% paraplegia rate through lower body perfusion to minimize spinal cord and visceral organ ischemia. Blood supply to the spinal cord relies on 3 longitudinal arteries: the anterior spinal artery located in the anterior median position and supplying 75% of the spinal cord, and the paired posterior spinal artery located at the nail ports. Segmental intercostal and lumbar arteries originating from the posterior aspect of the aorta supply serious unpaired arteries, contributing in flow to the anterior spinal artery. So the risk of cord ischemia during aortic cross clamp at the isthmus and associated paraplegia rates, clamping proximal to the left subclavian compromising flow into the left vertebra and further threatening the integrity of the spine. The posterior spinal arteries are supplied by small radicular artery that originating from the aorta at nearly every spinal level. Radicularis magna, the largest of them, originating at the level of T10 and entering the vertebral column at the first lumbar vertebra, essential for spinal cord perfusion in nearly 25% of the patients. So cross-clamp, some group report low paraplegia rate exclusively using a clamp and sew technique. However, these results are not widely reproducible and rely on cross-clamp time of less than 30 minutes. Fragility of the aortic wall, anatomical distortion by the peri-aortic hematoma, and extension of the defect into the left subclavian artery pose significant obstacles, and the average cross-clamp time reported in the literature is 41 minutes. So the paraplegia rates are greatly reduced and may even approach 0 when extracorporeal lower body perfusion technique are used. This is the two tables showing the incidence of post-operative paraplegia in a meta-analysis where we can see that the higher paraplegia is when no shunt is used, and the lower when the bypass is used. The AAST prospective trial showed that the higher of paraplegia come with the clamp and sew technique, where the lower come with the GOT shunt or passive shunt. That will take us to the adjuvantary perfusion techniques. Elective repair of thoracic or thoracoabdominal aneurysm allow employment of the several techniques to minimize spinal cord ischemia. Perioperative preparation required to monitor somatosensory evoked potentials, provide lumbar cerebrospinal fluid drainage, or achieve epidural cooling, where this is not available in a trauma setting. Hypothermic circulatory arrest technique have been successfully applied to injuries involving the arch, but are not practical when partial bypass systems are employed. It is important to be well versed in the various lower body perfusion systems because distinct circumstances may require alteration in practice. So intra-arterial blood pressure monitoring of both upper and lower limbs should be performed with a goal perfusion pressure between 60 to 70. Systemic heparinization poses a significant risk of hemorrhage in trauma patients, particularly in those with severe lung or intracranial injuries. Using a centrifugal pump with a heparin-bounded tubing and active partial left heart bypass, or using a heparin-bounded passive shunt is an option that does not require systemic heparinization. Although it showed that safe using of partial left heart bypass with a full system systemic heparinization has been reported as well. So the partial left heart bypass. Pump inflow is established by cannulating the left atrium through the left inferior pulmonary vein using small single or dual stage cannula. When pulmonary veins cannulating with the left atrium has demonstrated a lower complication rate than cannulating the left atrial appendage. So the arterial cannulation may occur through the distal descending aorta or the femoral artery. It has the advantage of convincing and speed. So the partial left heart bypass serves several purposes. First, to unload the left heart and control proximal hypertension at this time of the cross-clamping, to maintain lower body perfusion, to allow rapid infusion of the volume, and to control intravascular volume. Lower body MAB should be maintained at 60 to 70, and this can typically be accomplished with a perfusion flow rate 2 to 3 liters per minute. So the MAB 70 to 80 are generated in the upper body by the native heart, and ventricular arrhythmia remain a significant risk. The cell saver are employed to retain blood from the field, and heat exchanger can be used to maintain core temperature above 35. If the system is used without systemic heparinization, the heat exchanger and oxygenator should be removed from the circuit to minimize the thrombotic risk. In a full or partial bypass, a long venous catheter with multiple side holes may be introduced through the left common femoral vein and placed in the right atrium. Alternative direct right atrial cannulation at the inferior vena cava, right atrial junction may be accomplished from the left thoracotomy by simple transverse inferior pericardiotomy below the left phrenic nerve. Right atrial femoral arterial bypass has also been used with or without an oxygenator like partial left heart bypass. So a partial arterial oxygen pressure of 40 millimeters has been reported in non-oxygenated circuits, a level shown to be sufficient for lower body tissue oxygenation when the hemoglobin is 10. In cases of aortic arch injury, full bypass is beneficial. Partial or complete bypass may be established before entering the chest by bruising the right femoral veins to arterial bypass. A technique particularly advantageous when concomitant right lung contusion inhibits oxygenation. In case of arch transection, in proximity to the innominate or left common carotid, anterior exposure via the sternotomy or thoracosternotomy may offer better exposure for the total arch replacement under the hypothermic circulatory arrest. When we're using the hypothermic circulatory arrest in trauma patients poses a significant bleeding risk. So when a hypothermic arrest is used within the left chest, the left ventricle should be vented through the left atrium. So the aortic injuries required, this technique may be appropriate for anti-impulse therapy and delay and repair until other concomitant injuries have been addressed. So that will take us to the passive shunt, where the proximal and distal end of the tube are placed in the ascending aorta or arch with the descending aorta or femoral artery. Ventricular cannulation had been used in the past, was abandoned because of the high rate of ventricular arrhythmia, reduced shunt flow, and high rate of paraplegia. Flow through this fixed tube is dependent on the pressure gradient, and this inability to control flow is the main disadvantage. Offers no left ventricular unloading or loading advantage. This is an advantage. So the operative technique, patients are positioned in the right lateral decubitus position with the left groin pribbed for the arterial and venous axis. A right radial arterial line is preferred. to avoid losing arterial pressure tracing of if the occlusion in the left subclavian artery is required. Using a pulmonary arterial catheter, this is an optional. Selective ventilation of the right lung is required. So a standard fourth interspace posterolateral thoracotomy with or without fifth rib notching usually provide an excellent exposure to the aortic isthmus and proximal descending aorta. The incision should be long enough to facilitate dissection of the descending thoracic aorta below the level of the inferior pulmonary vein and dissection of the arch of the aorta between the left common carotid and the left subclavian artery. So a prior left thoracotomy offers both an advantage and disadvantage. The adhesion between the lung and the mediastinum help in containing the rupture, making it less likely to bleed. Dissection near the isthmus or tear should be avoided until both the proximal and the distal aortic control is established. Lower body perfusion can be established before the aortic exposure. So, depending on the stability of the patient, the left inferior pulmonary vein, left atrial junction is dissected and cannulated, in the addition to arterial cannulation of the distal descending thoracic aorta or left common carotid. Excessive compression or traction in the lung should be avoided, particularly when dissecting out of the aortic arch, because the left pulmonary artery may be easily disrupted. So distal control is obtained first, usually by passaging the blunt instrument or finger around the descending aorta at the distal margin of the hematoma. Care must be taken not to involve the intercostal arteries branches with this maneuver. So the subclavian artery is isolated. Care is taken to avoid injury to either the phrenic or vagus nerves, should be reflected off the aorta with overlying pleura and retracted medially by attaching a stay suture to the pleura just lateral to the vagus nerve. This reflection exposes the arch of the aorta between the left common carotid and left subclavian arches, which is the point needed for proximal control. This exposes the ligamentum arteriosum, which can be sharply divided. Careful dissection between the left common carotid and the left subclavian artery using a combination of sharp and gentle fingers dissection to completely encircling the aortic arch. There should be no dissection distal to the subclavian or the ligamentum to avoid free disruption of the hematoma. So aortic disruption that occur in close proximity less than 1 centimeter from the left subclavian carry high mortality risk and greater operative difficulty than injuries further away. So the upper and lower body pressure are stabilized with bypass circuit to maintain the upper body map 70 to 80 and the lower body pressure 60 to 70 with a flow rate of 2 to 3 liters. Pre-aortic hematoma is been entered and the edges of the transected aorta are identified. Usually the aorta is completely transected and the edges are separated by 2 to 3 centimeters and placing a short interposition graft. Grafts are sewn using a running suture with the proximal anastomosis performed first, followed by the distal. If the proximal anastomosis is done under the hypothermic arrest, bypass and reperfusion of the arch should be reinstituted immediately after the completion of the proximal anastomosis for optimal neurocerebral protection. So the left subclavian can either be incorporated into the proximal anastomosis or grafted separately, cooled to the 20 degrees Celsius and use cerebral protection adjuvant, including packing the head in ice and 15 milligram of sodium thiopental Prepare to vent the left ventricular apex if the distension occurs as a result of cooling-induced fibrillation. If the aorta is already ruptured, with the bleeding into the hemothorax, proximal aortic dissection between the left carotid and subclavian artery is rapidly performed and cross-clamped quickly. The distending aorta is then clamped below the injury and the hematoma is opened. So in cases the aortic tear extended to the left subclavian, the proximal clamp may have to partially or totally occlude the left common carotid. Deattach from the aorta, proximal anastomosis completed, clamp move distally to the graft, then reattach to the aortic graft with interpositioning the graft after completing the distal aortic anastomosis. The left subclavian interposition graft with an end-to-end anastomosis distally and proximally into site. So now we'll talk about the endovascular stent or TEVAR of the descending aorta. So this technology was initially applied to a patient considered extremely high risk for open repair in such a head injury, abdominal visceral, intra-abdominal hemorrhage, or severe pulmonary contusion. Theoretically, advantage of the stent graft include avoidance of the thoracotomy, one lung ventilation, the systemic effect of the bypass, aortic clamping, and spinal cord ischemia. In patients with stable aortic injury, grade 2 and 3, the timing of the intervention is usually detected by the severity of association non-aortic injuries. Proper anti-impulse control, delaying management of the plunge trauma until the life-threatening non-aortic injuries have been treated, shown to be safe and beneficial approach. So patients with other serious injuries, the trend to treat grade 2 and 3 injuries within 24 hours to avoid progression to grade 4. A proximal landing zone of at least 1.5 centimeters is considered necessary to achieve reliable seal, raising the concern of the left arm ischemia of the left subclavian need to be covered. So case of systemic left arm ischemia, electively carotid to subclavian bypass may be performed. Commercially available thoracic aortic stent graft have been designed for treatment of the aneurysms. Therefore, diameters are often too large for the trauma patients. The ideal device for the repair of traumatic aortic injury should be 16 to 14 millimeter in diameter, 5, 10, and 15 centimeter in length, and conform to a 90-degree curvature without deformation. Decreased operating room time, dimension physiological derangement and hypothermia, decreasing intrafusion rate, shorter intensive ICU staying or overall hospital stays have been documented in a series directly comparing open to endovascular repair. So the paraplegia and mortality rate are also markedly reduced to nearly zero. Long-term surveillance is recommended to evaluate for endoleak or stent migration or delayed pseudoaneurysmal formation. So I think I've finished. If Dr. Fahad have any notes to add. Hello? Hello? Comment? Anyway, thank you so much.
يعطيك العافية عبد الرحمن.
الله يعافيك.
يعطيك العافية عبد الرحمن.
الله يعافيكم.